Okay, welcome everyone. Welcome. This is the session on border violence, detention, and pushbacks in Europe, a determinant of health. It's great to see so many of you here today. I'm Rosie, the coordinator for the Lancet Migration European Hub, which is based in the Geneva Center of Humanitarian Studies, and I will be your moderator today. So we have two really interesting presentations, followed by a very interactive discussion, because we're interested to hear your thoughts and experiences. So Lancet Migration, you may or may not be familiar with it. It's under the umbrella of the Lancet Journal, and it's a group of migration and health researchers. We represent the European Regional Hub. There's also a Latin America hub with plans to develop other regional hubs in the future. And we try to combine research with policy and practice to develop guidance and best practice examples. So the European Hub was launched in 2021, and we aim to advance regional research on migration, disseminate knowledge, not only to other researchers and health professionals, but also to policymakers, and to engage with the public. We have three working groups at the moment, with plans to develop these based on regional priorities over the years. And this presentation will be part of the working group on border security, detention, and health. So without further ado, I will introduce our first speaker. She is a PhD candidate at the University of Heidelberg in Germany, and she's supervised by one of our Lancet Migration professors, Kevon Borgsheimer, who couldn't be here today. But she's going to present the preliminary findings from our systematic review on border violence in Europe. Thank you.
Good morning, everyone. Thank you, Rosie, for the nice introduction. And mostly thank you for organizing this session and making it possible for us to present our work. So my name is Zahia Wasko. I am from the University of Heidelberg, Germany. And I'm very happy to be here with you today to share with you our work on border violence, specifically on pushbacks and violence towards migrants crossing the borders. So this project is in collaboration with the Lancet Migration European Hub. It wouldn't have been possible if it wasn't for those wonderful young professionals who mainly are volunteering and been dedicated since January to our project. So before I move forward with my presentation, I would like to express my gratitude to each one of them. So why are we here? And why are we talking about pushback practices? In fact, in the last decade, specifically since 2015, when the migration crisis hit Europe, we have been witnessing a surge of the implementation of pushback practices, and this was alongside constant reporting on violence towards migrants. These reports have emerged in the media from journalists, activists, as well as organizations, national and international, and NGOs. But despite this development and these sounding alarms, we still do not have evidence that makes us understand the magnitude of the problem, nor do we understand the effects of these pushback practices on the health of the migrants. So this was our motive, basically, to start this project, this research activity, and our aim is to synthesize from a health perspective the effects of the use of violence related to pushback practices targeted towards migrants in the European borders. Other objectives are to obtain a realist view of the magnitude of the problem and also to understand the different actors and the, the power play rules. So what are pushbacks? The definition you see right now on the screen has been retrieved from the website of the European Center for Constitutional and Human Rights. And I see it as a short version of what the UN Special Rapporteur, Mr. Morales Gonzalez, have written in his report in 2021, where he defined pushbacks as the different measures, actions, policies that are taken by states directly or indirectly, so through a third country or also a private agency. And the aim of these actions is basically to force migrants back, force migrants individually but also collectively back to where they have crossed or tried to cross an international border by land or sea before assessing their protection needs. And when we look at this definition, it becomes very clear that pushbacks actually are a violation of the UN Refugee Convention. And just to remind you a bit, the Refugee Convention has been signed already by 149 states, to include the European states, and it is based on the principle of non-refoulement, which emphasizes that refugees must not be sent back to a country where they might face a threat for their life or freedom. Another violation is, well, pushbacks are also a violation of the EU Charter of Fundamental Rights, even though the EU Charter does not explicitly condemn refoulement, but it prohibits the risk of torture and risk of inhumane treatment. And here I just want to also point out that the EU court has already stated that pushbacks expose migrants by turning them back to that prohibited risk. So, another term I would like to highlight before we move on is violence, and in that sense, we adopted the definition from the WHO, which states that violence is an intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injuries, death, psychological harm, maldevelopment, or deprivation. And the WHO also highlights violence as a public concern, as it causes a significant portion of the death and disabilities around the world. What the WHO also states or has developed is this ecological framework. So basically, it is believed, or it's evidence-based, that a single factor could not be accorded to why some people are subjected, some people or some group of people are at a higher risk to be subjected to interpersonal violence. It's usually an interaction of many factors that fall under four main levels, which are the individual, relationship, community, and societal. And the good news about that is that we can prevent violence. However, the best strategy to prevent it is first to identify the risks and then to tailor the right intervention strategies. So to move back to our project on pushbacks, we have taken the two components in our research, the qualitative and the quantitative. In terms of qualitative analysis, we have conducted a systematic review of the peer-reviewed literature that have been published since 2010, and we retrieved them from 3 different databases: PsycInfo, Web of Science, and PubMed. And we also included gray literature reports from authoritative organization, and to be able to identify the main and more important, or the important organization that already work in the border violence, we have consulted key informants. And in terms of quantitative analysis, we used an open source data from the Border Violence Monitoring Network. For those of you who don't know the Border Violence Monitoring Network, it's a network of many NGOs that currently is located in the Balkan, Greece area, and they have got together in 2016 and created this repository of pushback incidents. So basically what they do, they collect information on pushback incidents from testimonies given by victims or also eyewitness. And before they put them in their database, they run them through fact checks. So this is what we also used to analyze and help us reach our objectives. What I want to highlight is that our project is still in process, especially the systematic review. We have already gone through 2-stage screening of the included literature, and what I want to highlight here is that most of our included literature is actually from the gray literature. The peer-reviewed literature, we found 42 articles, and they are mainly qualitative data based on ethnographic research, while in the gray literature we found 346 articles, and from those we included 197. We also performed a quality appraisal before we went on to the data extraction to keep the analysis at a quality, especially that most of our literature comes from the gray literature, which is not peer-reviewed usually. And this is our Prisma chart so far. So it just summarizes what I have pointed out earlier in the slides. Currently, we have right now 182 articles or reports to extract data from. And these are the results of the quality appraisal. What you could see here is the type of literature we have. So as I pointed out earlier, the gray reports make most of our included literature, and then we have the qualitative followed by cross-sectional mixed method and case report. What I can tell you right now about what we noticed through our systematic review is that our literature already covers all main EU migratory routes. We have reports on Central, Eastern, Western Mediterranean, Atlantic, and Eastern Europe. And all these reports have evidence, some kind of evidence on pushbacks, practices and the violence related to these practices. And it involves EU states, either directly or indirectly. And it always highlights the health of migrants. So, as I said, right now we just started extracting the data. We will be focusing, while extracting the data, on 3 aspects, which are the pushback, violence, and health outcomes. And we will try to capture the context of the pushback, so what is the practice that have been used, how many migrants have been affected by it, and who are the actors that have been involved. We will also capture the health outcomes in terms of physical, mental, and also access to needs. And in regards to the violence, we here also will extract the type of violence according to the WHO typology, which covers physical, psychological, sexual, and structural violence. And so I move on to the quantitative part. So as I said, we analyze the data from the Border Violence Monitoring Network. And as a first level analysis, I could tell you that the data set offers data for 1,709 pushback incidents that happened on the European border from January 2017 until March 2023, when we extracted the data, basically. And so the unit of observation in this data set is actually the pushback incident. These 1,709 pushback incidents have affected 31,050 individuals. And also what I want to mention here, the data set shows us 249 type of violence, which we cleaned because some of the strings had the same content but were worded differently, and we cleaned the data and ended up with 39 different type of violence. On the second level, we tried to count how many violence entity has been found in the data set. This means, for example, counting every entity. So I said we ended up with 39 type or entity of violence. We sum up these entities and we came up to this number, which is 6,861 violence entity count. And we did the same thing with the violence entity victim. So we took each entity and we counted how many individuals were exposed to this entity. And in that sense, for example, if you have a sample of 25 migrants and these migrants have been exposed to, for example, deprivation of personal belongings, 25 of them, for example, have been exposed to deprivation of belongings and also been pushed. We counted them twice, so it's like 50 persons have been exposed to these violence entities. And we came up with this number, sorry. It's not moved. Ah, here we go. Sorry. Okay, so I just wanted to tell you it's about 140,000 people that are exposed to violence entity victims, basically. It's an exposition of the number. Another finding I would like to show you is this chart. Here you could see the range of the different violence that have been seen, and you could see that it's quite frequent and quite diverse. So like the deprivation of material personal belongings takes the first place. Yeah. And here is the number of violence victims by violence entities, so how many people are exposed to each type of violence. Also for our quantitative data, we ended up categorizing the violence by the WHO typology, and this is the result here. So yeah, as I said, it's quite frequent and quite diverse, the type of violence that has been seen on the European borders. So this brings me to my last point. So even though the work is not yet completed and we are looking forward to complete it in February, but we could already say that violence and pushbacks are two phenomena occurring simultaneously and exposing migrants to degrading and inhumane treatments. What I could also say that pushbacks and related violence are frequent at the EU borders among migrants and indicate the existence of a systematic issue in approaching the border management. Yeah, with that, thank you. I'll take my stuff.
Thank you, Zahra. Are there any questions about this presentation or the next steps? Yeah, we have a volunteer for the microphone, thanks.
Yeah.
Maybe I can try. You can throw it, yeah.
Thank you very much for the presentation. My name is Helene Kades. I work for a Dutch institute that also focuses on migrant health. I was looking at the results on the most common forms of violence, and I saw that there was a relatively low number of sexual violence. And I was wondering if some of these results might be influenced, for instance, by topics that are taboo or difficult to address.
Yes, thank you for your question. I agree with you, and I also think it's underrepresented in our data. I think it's very hard for people when they are giving a testimony maybe to open up and tell everything, and maybe this is why we see the sexual assault going. But if we go back to where we put them in categories, you could see that they are still high on the chart. So maybe the number is here very low, but when we expose, and when we do the exposition, then you could see that it's already, yeah.
And this is only the quantitative data. I think in the qualitative data we'll have higher numbers as well, exactly. Because it was at least 20% in some cases.
Yeah.
There was another question here.
My name is Abdul. I work with Vrije University Amsterdam. I'm from India. My question is actually related to knowledge production. In your data analysis, you showed that you got more grey literature than the peer-reviewed literature. I was wondering, is it because some sort of epistemic violence in mainstream knowledge production system, it's very difficult to get published when you are talking about pushback, migrants' rights? Because from my experience, I work with in situ stateless people in India, in Assam. Since till 2010, there was huge pushback. But if you go through the literature, you won't find those in mainstream knowledge production like the CNLs, especially the peer-reviewed paper. So I was wondering, what is your experience in this? Thank you.
Yeah, I think that's one of our expected findings, and it's something we can use to advocate for more research, because we actually, I think we found more studies than we expected. There was 45 peer review, which I thought was quite a lot, but since 2010, but I think it's something that we need to advocate for, and that's why we're presenting here to health researchers and medical professionals, because it's something that we need to document more systematically. Yeah.
Sorry. So also in my opinion, it's because all these organizations who work on border violence are grassroots, and most of them are just humanitarian. They started as a humanitarian group who started helping migrants, and they are not very well established. And the data, as a result, no one is putting together a data set that could be analyzed. That's my opinion. So we found some reports that are quite strong from the MSF, for example, and there are other organizations that have been collecting some data, but the data is never very explicit to cover the whole Europe. Yeah, and as Rosie said, I think this is also one of our aim is to make more fun.
And another point would be that the first point of contact in a lot of these cases is the NGO, and we'll hear from MSF next. So a lot of these migrants may not have first contact with a health professional to document this sort of violence. Maybe one more question, and then we'll have lots of time at the end after the second presentation for more discussion.
Salvador? Oh, thank you.
Hi, thank you so much for your presentation. I was wondering, a lot of times the actor of the violence can be very important, like police can cause a lot of violence, destruction of property, physical violence, but also private actors can as well. So I was wondering if within the data sets you have a way to distinguish between that. And also, there are most individuals I think that undergo this violence would undergo it more than once. So if you've considered like how to deal with like the repeat of individuals who undergo the violence over and over again.
I didn't quite catch. So
the first question was about whether we are going to analyze who inflicts the violence,
yes.
whether it's police, border guards, etc.
This is what we meant by actors. So one of our objectives is to look at the different actors, and in the data set, though, when we analyzed it, there wasn't a lot of data on this. In this sense, they had one column which says police, yes or no. Police present, yes or no. But they didn't capture other actors. So this is why you don't see it in the quantitative. In the qualitative, it's still in process. It's one of our themes that we want to extract data on.
Yeah, definitely police and border guards are quite frequently reported as the inflictors of the violence, as well as in the camp setting, interpersonal violence. Maybe one more question?
I think Salvador wanted to ask. Yeah, I see. Okay.
Thank you. My name's Jamila. I'm a physician of global health, and I actually do research on the Greek islands as well. First of all, thank you so much for shedding light on this very important and crucial topic. I have two questions. My first one is relating to trends, and whether if you've looked at that, you've looked at literature from 2010, and if there's been any changes over the years, perhaps related to policies or European laws. And my second question relates, actually building on Helene's question on the definition of the pushback. You mentioned the definition, but I was wondering what time frame you're looking at. So, for example, with the sexual violence, are you looking as well at, for instance, sexual violence in detention centers in Turkey, for instance, where after the pushback, upon arrival on the European shore, so how do you define the time period of the pushback? Thank you.
So in regards to the time period is while crossing, so either attempting to cross or crossing, which means if they are already registered, right now we're not capturing any violence that comes after registration, or also the violence that is not clear if it's related to government entities. So, for example, human trafficking and, for example, some of the sexual assault that is that one is affected by while taking the journey, but has nothing to do with police, for example, or the government. We're not capturing those. So just at the borders while crossing. If they were pushed back, what happened during that incident?
Okay, thank you for all your questions. And there'll be lots of time after the next presentation. So now I'm very pleased to introduce Dr. Chloe Marshall-Denton. She is a humanitarian affairs advisor at the MSF office in Brussels. She holds a master's in migration studies and a PhD in international development, which focused on migration from the University of Oxford. And she will speak to us about some field experience on this topic. Thank you so much.
Thank you. Yes, thank you. Good morning, everyone. And as Rosie mentioned, I'll be complementing the first presentation by bringing a little bit more of an operational and field perspective onto the question of border violence. So I'll be bringing the perspective of the field coming from Doctors Without Borders, MSF, looking at the health and humanitarian consequences that we see on the ground of this violence. But quickly first, a word on sort of MSF's background in responding to migration and displacement. So MSF has a long history of responding to forced displacement, and I think there are images that are often conjured up when thinking about MSF. We might think about MSF responding to conflict zones and internal displacement in DRC, South Sudan, or even in response in the 1970s to displacement from Vietnam or Cambodia. And this is also the case. It is a portion of what we do today. However, over the last couple of decades, more than responding to sort of the inherent medical needs that people have, we're increasingly responding to the health consequences of restrictive border policies. So over the last couple of decades, our operational presence has grown across border areas, and in particular across European states, where we see that we're actually responding to the consequences of restrictive migration policies and the effects, of course, that they have on our patients. So this has especially been the case in Europe. It's not only the case in Europe, we also see similar trends in Latin America, in particular with changing developments with the US. And it's important to note that migration itself does not have an automatically negative effect, but it's all of the policies that are put in place in order to respond to them, which then become a determinant of people's health in the context of migration. So to begin, in the next slides, I'll be drawing mostly from MSF's operational data, as I mentioned, through our field operations across European migration settings. But of course, behind all of this operational data, there are people. And in this context, there are patients whose lives have been unnecessarily put at risk and whose well-being has been deeply harmed by the policies that we'll be talking about today. And by this, I mention the policies being all of the policies and practices around border violence. And to give a bit more of a human perspective behind this operational data or aggregated data that I'm going to show, I will also be relying on testimonies from our patients as well as our colleagues in the field. Maybe just to warn, some of the testimony material is quite difficult and could be a little bit triggering. So firstly, when we talk about border violence as seen from the field, there are maybe different conceptual definitions of border violence that can be thought about. From our perspective, border violence as we see it is a set of policies and practices that involves many different components. So of course, there's the actual act, as Daria mentioned, of pushbacks. So the act of what happens when someone crosses the border or immediately after crossing the border. But all around that, there's a whole system which tries to prevent people from accessing territory. This includes the denial of assistance and the denial of search and rescue at sea. It includes as well the physical infrastructure of a border. So we can think about a fence. We can think about the extremely sharp razor wire that is increasingly being put on top of border walls and fences. And there's also all of the surveillance infrastructure. So these walls and fences have been complemented by drones, high-tech surveillance, which means that people have to move faster and which also makes the crossing more difficult. And then inherent to the pushbacks, as was shown in the last presentation, is also the widespread use of forms of violence during the course of pushing people back. So we can think about physical violence as well as degrading treatment, most often committed by state and parastate actors. And then, so this is sort of the tip of the iceberg of what we see. And there's a previous question from the audience about sort of the epistemic violence around this. And I think one important element from our perspective is the fact that increasingly in these areas where we see border violence, we also see an increasing obstruction of humanitarian assistance. So we see administrative and legal measures being put in place by states which aim to obstruct visibility and humanitarian access on a particular site. So most often in border areas, it's become increasingly difficult to reach people. As a consequence, it's also increasingly difficult to shed light or scrutiny on these practices, which I think is also one reason why there's very little sort of established knowledge on the consequences of these practices. And of course, also as a byproduct of that, it's most importantly become increasingly difficult to reach people where they need it and when they need it. And then in addition to that, as an extension of border violence is also all of the coercive and punitive measures that meet people on arrival. So once they actually do manage to cross a border, being met with forms of criminalization, detention, coercive means which further undermine their health and well-being. As I mentioned, MSF has expanded its operational presence across European borders over the last couple of decades. Today, this is a sort of a partial map of where we're present, both in Europe as well as just beyond European borders. So if we think about the central, or the so-called central Mediterranean migration route, we have a presence in Libya, in the Mediterranean Sea with our search and rescue vessel, as well as in Italy to meet people on arrival. In the Eastern Mediterranean, we have a presence on the islands of Lesbos and Samos, where we meet people having crossed from Turkey. And then in the Balkans, we have a presence in southern Serbia and northern Serbia. So in southern Serbia, where we see people having crossed through quite a perilous journey from Bulgaria, oftentimes on foot. And in northern Serbia, where we meet people having been pushed back from Hungary. And then finally, at the border between France and Italy, we're present in the city of Ventimiglia in Italy, where we also see people having been pushed back. And then it's not visible on the map, but we are also present at the border between Belarus and Poland, so on the Polish side, where there's also been widespread use of pushback practices. I think what's important to note here is that across these settings, we see the various elements of the border violence that I highlighted in the last slide. We see, to various extents, all of these elements being present across these contexts. And this also confirms the fact that across all of these contexts, as a medical humanitarian organization, what we're actually responding to is the consequences of entirely unnecessary violence. So first, to delve into some of these elements in the first slide, I would like to illustrate from a bit more of a human perspective how a pushback is experienced. So I'll read an excerpt from a testimony that we have from one of our patients who shared this with us on the island of Lesbos. And this pushback, or this testimony is describing someone who's been pushed back after having arrived by boat on the island. So from the perspective of our patient. We jumped out of the boat and walked through the water to the beach. We made it. We went to a place with many bushes and sat down. I was so cold and wet that I could hear my teeth clicking on each other. I was shivering. What do we do now? We asked. Suddenly, we were surrounded by many men with weapons, again with covered faces, just like the men on the boat last time. I think it was 8 of them, or even more. They made hand gestures that we had to get up. Most of us did, but 2 boys stayed on the ground, and that's when it all started. One of the men shouted and started beating the boys. He kicked one of them in the stomach, in his side, in his back, on his head. "You do what I say," he shouted. Some of us were so shocked that we started screaming, and then the other men started beating us too, all of us, everywhere. We were pulled and pushed into a line, and we had to give them everything we had, our phones, our money. A small van arrived, and we were all pushed inside it, in the back, on top of each other. I could barely breathe. They drove fast over many bumps and through many turns. Finally, we stopped. There was a boat, and it looked like the boat I saw last time. and I knew what was going to happen. We were kicked and beaten one more time, and with their sticks, they were guiding us to get on the boat, as if we were sheep. But a shepherd never beats his sheep. In the middle of the sea, they threw an orange floating thing in the water. It looked like a mattress with a cover, and one by one, we were pushed inside. The testimony ends there. So for the past 2 years, we have received repeated accounts of violence such as this one. Unfortunately, this is only one of the countless stories, such as this one from our patient, that people experience upon arriving at European borders. This is an account from Greece, but it's not only at Greek borders, importantly. For example, since 2001 in Poland has passed domestic legislation amendments that now provide legal grounds for border guards to push people back to Belarus, which means that today all people who manage to cross the 5.5 high meter border wall that's also lined with razor wire are immediately at risk of being returned to Belarus. And they're often, for lack of a better term, and to put it quite crudely, ping-ponged back and forth from the Belarusian side to the Polish side for protracted periods of time. Some patients report having been pushed back as many as 20 times, and on almost each of those occasions, they face egregious forms of violence. In Greece, as was shown by the testimony from our patients continue to report having experienced pushbacks from land and sea, again, oftentimes multiple, successive forms of violence and pushbacks before finally arriving when we finally see them. So by way of indication, we collected 56 recorded accounts received from our patients on Samos and Lesbos, and across those 56 individuals, they reported to have experienced a total of 183 pushbacks. In 9 of those accounts or testimonies, patients described having been pushed back between 8 and 14 times. Of course, this is not necessarily completely representative, but it does reflect a wider pattern. In northern Serbia, we meet people stranded for long periods of time in informal settlements, where they attempt to cross into the EU via Hungary and are again met with razor wire fences, violence by border guards before being pushed back. And there we frequently treat the injuries linked to violence upon their forcible return to Serbia. Another example is with, so we've mostly been talking about the external borders of the EU, but we're also seeing an increasing use of violence at the internal borders of the EU. So since 2015, France has on and off reinstated internal border controls at the internal borders, so between France and Italy. And with that, we've seen that it's become increasingly difficult to cross. So in the city of Ventimiglia, on the Italian side, we meet people who every morning are pushed back to Italy after having spent the night detained in a container in substandard conditions. So I think that it's quite clear from this that there appears to be quite a widespread normalization of violent practices. And another thing that I hoped to bring to light through this slide is also the fact that people are often pushed into cycles of multiple pushbacks and abuse. And of course, these often have compounding effects. Inherent to the act of pushbacks is the use of violence. This was also mentioned in the last presentation. The most prevalent is sort of physical assault, so kicking, beatings, use of objects as well to beat people. And then we also see some forms of violence which are quite particular to specific settings. So in Poland and Belarus, what we see is really the fact that people are pushed back and forth for protracted periods of time and experience physical violence at the hands, as they report to us, at the hands of both the Polish and the Belarusian border guards. We also see across the board, but particularly in Poland and Hungary, the use of dogs to attack people. And then the use of detention in some settings. So for example, in Greece, as well as a pattern that we've seen in Hungary and France, where people are being informally detained, oftentimes in containers, before being pushed back. In the Greek context, we've also seen a very disturbing pattern of people disclosing to us having been strip searched or subjected to non-consensual strip searches and intrusive body searches. And this is often for the purpose of finding and taking people's money and other possessions. So our patients have described to us really the humiliation and the degrading treatment to which they're subjected during that process. They report men, women, and children being subjected to intrusive body searches. One patient, for example, described having been subjected to this on 3 separate occasions, which is 3 separate pushback occasions. And this is often accompanied by other violent acts such as beating, as well as dehumanizing and humiliating, often racialized language. So again, these forms of violence are generally interconnected. So if we see a statistic that X number of people report having been beaten, it's oftentimes accompanied by a range of other measures, which are quite devastating in consequence. So the obvious immediate consequence is a form of trauma to which people are exposed. In Poland, we see, for example, that 62.5% of the patients that we treat at the border we identify have the presence of trauma related to physical violence, mental health trauma, or sexual violence, which is disturbingly high. In Serbia, we've provided medical legal certification to 297 patients as a result of reported violence. And in 71% of those cases, they reported this violence to have been carried out in the course of pushbacks. And the main injuries that we treat in northern Serbia are contusions, fractures, hematoma, lacerations, and sprains. But in addition to that, so these are a little bit the direct consequences of this violence and pushbacks, I think it's also really important to think about the indirect consequences, which is that people, when they arrive within the European country, know that there's a high risk of being pushed back. So they're also pushed into quite an acute state of fear and are forced into hiding on arrival. Which also means that during this period of being in hiding, they're exposed to the elements. They oftentimes are deprived of food and clean water, and are at high risk of being injured. So again, I would like to turn to a testimony from one of our patients, again from the island of Lesbos. So this testimony describes having arrived on the island and then trying to find a safe place to hide out of fear of being pushed back. We tried to climb up the hill, and as we were climbing, the terrain broke and a big rock fell on the face of my wife, followed by a rain of stones that fell on her head. She was injured and bleeding from her head. I told her to sit while me and my 2 children were trying to climb up the mountains to find someone of the other group to come and help us. Her face and head were covered in blood. We climbed a bit more and walked for some time until we reached a flat place where there was a road passing. We tried to hide as we were very scared the police would pass by the road. I had not had anything to drink since Turkey. I was thirsty, and my children too. So unsurprisingly, by the time our medical teams reach groups who are arriving, people are in an acute state of fear. And the most frequent observation is the mental health distress that people are in by the time we reach them. So again, to turn to this time the voice of one of our colleagues in the field describing reaching some of our patients. So this is from the island of Lesbos, where when we arrive in these remote locations, we start calling out saying that medical help has arrived. So as soon as we started calling them with the megaphone, we heard screams calling for help. The area was very forested, and we could not easily spot the people. When they realized our position, they came running down the hill in severe distress. 2 small girls were in distress because of splitting from their mom and crying. A young man was in severe distress that led to a panic attack. Both of his arms were in dystonia, in muscle spasms, and he was hyperventilating. And this is essentially the routine sort of notes that are taken after an intervention from our teams in the field, where people are experiencing unbearable levels of fear as a result of the risk of being pushed back. So essentially, for example, in the case of Poland, to bring it back to another case, most of the people that we see by the time we reach them, again, in the densely and remote forested area of the Polish-Belarusian border, report to us having been in the forest for at least 48 hours. And some of them report having been stuck in the forest for over 1 week with limited to no access to food or water. And I think it's important to note also that during the course of pushbacks, oftentimes border guards take people's personal belongings, so phones, clothes, things that allow them to survive, essentially, to use a GPS, or even warm clothes to be able to survive in the forest. So unsurprisingly, some of the main morbidities that we see in this context are general exhaustion, hypothermia, frostbite, and trench foot. Similarly, in Greece, so in line with the testimonies that I described, in the 2-year period, so 2021 and 2023, we conducted 557 wound dressings. Many of them were linked to injuries sustained by climbing dangerous terrain. But through our interventions, we also encounter highly vulnerable groups, including women, for example, who are in late stages of pregnancy, as well as infants, people who have chronic illnesses, who should absolutely be able to access needed care on arrival, and yet are forced into the state of fear and of hiding. So we conducted a total of 155 people were urgently transferred to hospital by ambulance for further medical care. And of course, this is exacerbated by the fact that they cannot access care on arrival out of fear. In southern Serbia, as I mentioned, we treat people who have gone through the long journey across Bulgaria, oftentimes by foot, through a mountainous terrain that often reaches sub-zero weather conditions in the winter. Here again, we've conducted a quite significant number of wound dressings in a short period of time, so 2,212 wound dressings. And the main morbidities that we've treated in this context have been skin-related scabies, trench foot, accidental trauma, gastritis, and upper respiratory tract infection. And all of these are generally linked to the conditions of the route and the conditions in which people have been forced to experience along their journey. Then another sort of aspect of the border violence that I mentioned was the border fence as a form of violence as well. So one very sort of typical case study is in the case of Poland. In 2022, they erected a 5.5 meter high razor wire border wall. And what we see is that 40% of our patients have sustained injuries as a result of the infrastructure of the wall. So we see blunt injuries, sprains, deep cuts, and suspected fractures. And almost half of the referrals that we've made to hospital, so urgent referrals from the forest, have been related to orthopedic needs and wounds having resulted from the razor wire. So it induces quite deep cuts. And I think interesting to note that even the manufacturers of razor wire say that it will injure and maim. But I mean, maybe just on the border fence, we are seeing a complete proliferation of these border fences across European states. I think it's interesting to note that this was illustrated with Poland, but today there's over 2,000 kilometers of European borders that are covered by border walls, and oftentimes, again, complemented by razor wire and other surveillance means. And then one sort of final example of this border violence is the lack of assistance at sea, endangerment practices at sea, as well as the lack of search and rescue. So what we're seeing today is a complete failure of European states to coordinate effective search and rescue at sea. We also see that there's an increasing criminalization of the activities of civilian search and rescue. So we can think about NGOs who are operating search and rescue boats on the Mediterranean, including MSF. And then the actual endangerment practices that are employed by European coast guards or coast guards that are supported by European member states and the EU. We can think about the Libyan Coast Guard and the Tunisian Coast Guard. This has, of course, resulted in acute medical needs by the time people arrive in Europe or by the time they are rescued, for example, in the Mediterranean. It has resulted in shipwrecks, deaths at sea, and a significant amount of distress amongst people who do arrive. So this is data coming from our activities assisting survivors of shipwrecks. So on the left, we have shipwreck incidents on the Greek coast, and then on the right, we have shipwreck incidents off of the Italian coast. And I think it's important to note that this is just, a minor sample of all of the shipwrecks that have taken place. This is since 2002, but even all of the shipwrecks that have taken place since 2002. I won't go through it, but you can look at the number of fatalities linked to these shipwrecks. And these are only the ones where we provided as MSF support as a psychological first aid. But it represents just a sliver of people who have died in the last year, including in the Mediterranean. The last year was the deadliest since 2017. To illustrate one of these cases of responding to shipwreck survivors, I'm again returning to the context of Lesbos, so drawing from a testimony from one of our MSF doctors in Lesbos. So she describes having responded to the shipwreck on Lesbos, which caused the death of one person. So she says, a group appeared walking on the small dirt road among the olive groves. They said that people with black masks took others from the group minutes before MSF arrived. In front of a tall figure, a man holding a blanket in his hands, and a few other people following him close behind. Some were limping, some were not wearing shoes, all were crying. The tall man had in me a blanket with his 2-month-old son's body. He was crying in shock and could barely form a sentence. He kept saying, "My son drowned and they took my wife. I don't know where she is." The baby did not survive. The team was devastated. Some had to take breaks and cry behind our car. The father's words, the baby's face, the feeling of my fingers compressing his cold chest, the emergency blanket covering the body, all stayed in my mind for days. I felt hopeless and left completely alone, everyone turning a blind eye to our borders that have become graveyards. As the sun was setting behind the olive trees, nothing from the surroundings could suggest what had just happened there. Yet I will never forget the screams and tears from the group, the blood mixed with dirt under their feet, and the words from our psychologist, "He came to find a better life and lost everything." So when we think about the consequences of pushbacks, in addition to the immediate trauma and death that they're causing, we should also consider the long-term consequences. When these people do arrive on the shores of Europe, what are they met by? They're met by systemic policies of lack of care and of reception. They're put into centers such as detention centers or so-called open centers that strangely resemble detention centers. They're met with punitive, so these could be considered as punitive policies on arrival. And they're met with a lack of care. So they face huge barriers to be able to access needed medical care. And they also face forms of exclusion of certain groups. So what we see today within the EU is policies which appear to exclude systematically groups such as men in the context today of what's being negotiated in Belgium. So completely excluding them from accessing reception-related rights and needed care. And I think it's also really important to think of the impact of these sort of multiple, successive, and compounding forms of violence and trauma that people experience. Not only do they experience this violence at European borders, but many have already experienced violence along the journey, including in their countries of origin or in other transit countries, and are further exposed to violence on arrival at European borders, but even much longer thereafter through the forms of reception policies that are put in place. So as a conclusion, from our perspective and from what we see in the field, border violence has become a systematic and well-established practice, which is today at the core of border control. Europe was one example. We could bring other examples as well. But for that reason should be conceived of, and in particular within the framing of looking at it as a determinant of people's health, we should think of it as a significant public health concern. And from that perspective, also important to think, especially as medical practitioners, about the ways to challenge this today. And then finally, very clearly is the need to ensure appropriate care for people who are arriving at European borders, and to continue challenging and denouncing the policies that do not place the well-being and health of people at their center. Thank you.
Thank you so much for your presentation. Thank you for putting that in context, although it's really hard to hear and think about. I'll invite you to have a seat, and then we'll take some more questions. Maybe I can start. I'm wondering, Chloe, what are some of the policies you're seeing at the moment, and how they've changed over time to propagate this violence, and is there anything we can do to advocate against these?
I think some of these, some of the trends that I mentioned and that Zahia mentioned as well are long-standing. They're not necessarily new. If you think about violence at borders, if you think about pushback practices, let's say in the case of Greece, this has been reported for well over a decade now. I think what's shifting today is that while before there was sort of a denial of these practices happening, today there's a growing normalization of them happening in the open. So when we say a normalization, it's the fact that everyone knows that this is happening and it continues to happen. And I think what's even more worrying is that today at the European level, so at EU level, EU leaders are negotiating what we call the EU Pact on Migration and Asylum. And from our perspective, this development is extremely worrying because we see it as codifying and institutionalizing many of the dynamics that we've already been observing for the last 10 years. So when we talk about the dynamics which continue to incentivize states to employ violence, these are sort of what are being negotiated today at European level, and which risks completely becoming an accepted norm. So I think this is one of the most significant shifts. In terms of challenging, I think it really is about seeing where we can draw upon this body of evidence, we can draw upon what we understand as being the harmful consequences of this, and challenge policymakers. And for example, with the EU Pact, this is exactly the window to do so. So for people who are interested, it is a moment to a little bit raise our voice and raise our concerns, and I think as well to come from a bit more of a medical sort of background provides further legitimacy to this as well, and is generally heard. So I think to continue doing this, it has been done in other settings, for example, to challenge detention in the context of Nauru. Medical practitioners have been an important voice. And so I think it remains sort of central to continue doing this in this particular setting as well.
Thank you so much. Any questions? There's one in the front. Oh, she's bringing the...
Thank you. Hi, thank you very much to the whole panel for this great job that you're doing. And my question is in general to the panel as well. And is based on the fact that politicians normally react more favorably to economic indicators other than health, at least in my experience. Would it make sense, or maybe there is some data, or in case there is not, would it make sense to try to find a causal line between border violence and cultural perspective against the country that is creating cultural violence, and therefore have an implication on trade and negotiations? Was I clear, or?
I'm not sure I understood about you're saying about creating bilateral agreements for trade.
No, for example, that let's talk about the case of Mexico. I'm Mexican myself, and there is a lot of violence in the border, both in the south, the perpetrator is Mexico, and in the north, the perpetrator is USA. So whenever there is publicly open this data on the violence that the United States is perpetrating against Mexico, the Mexicans tend to have it very personal, and they stop buying some American products, which may have some implications for the trades, and they also try to push politicians to reduce the trade with the USA. Of course, this is an on and off, because then we forget and we continue our lives, but until the next bad news. And of course, the Mexicans, we treat differently the bad news from the south than from the north. So from the south is like we justify the violence in the sense like we are defending our country, and in the north we are the victims. So, yeah, but yeah. So the question was more related to the implications that have on the population, therefore on the politicians, therefore on the economics.
That's a good point. Yeah.
It's a really interesting question. I think in terms of economic indicators, people have looked at it in other ways as well. So looking at from our perspective, we talk about the human and health cost of these policies, but others look at the actual cost of these policies, and that has been another indicator to challenge the inefficiency and sort of counterproductivity of these actually quite costly policies as well from that perspective. But it would be interesting to see what's been done in the context of, as you mentioned, using that as a sort of lever to counter these dynamics. I'm not sure that.
So I see it as a politicization of the borders also. And we have seen it also in Europe. There have been deals between the EU and other countries to control the borders in a way, and the other countries have used also these deals to kind of pressure the EU in certain ways, be it to join the Union or in other aspects. So yeah, it's existing.
Any more questions? There's one up there. And while we wait for the mic, I have a question to Chloe about, you mentioned the medical legal certification that MSF assists with. What does that look like on the ground?
Well, it's just a form of basically understood as the patient's right to be entitled to documentation that reflects their condition. So it's just a form of documentation that's provided by the doctor or the medical professional, which attests to what has been treated and what has been seen.
And do you see them use that documentation when in their host country, or?
It could potentially be used in the host country. It could be used as a way to access further care. It can also be a useful form of documentation during asylum procedures, depending on the context and depending on the country as well. But it could certainly support as a form of sort of further proof, for example, in cases of injuries related to physical violence and so on.
Thank you. Question?
Yeah, my question was exactly on that one, on the medical legal certificates. Did other people also succeed that in terms that border guard got sued because of the violence which inflicted, because nevertheless it's crimes according to the legislation of the EU member states?
Could you repeat that? I think you're asking how they're...
Did with the medical legal certificates issued by MSF, did people who sustained violence, became victims of border violence, become successful in suing border guards, or were there any?
Yeah, it's... I'm not sure. I don't know. I don't have the answer to that question. There are many reasons why people might not pursue legal proceedings. Oftentimes, people want to get on with their lives. They want to reach where they hope to reach in terms of their own migration journey. In many cases, for example, in the context of Greece, where when we treat people as part of our sort of more comprehensive package of care, we can refer to legal partners, and it is the person's right to decide whether to press charges, for example. But in some contexts, we see that people are afraid that there will be negative consequences on them and on their asylum claim. So ultimately, many people choose not to sue or to press criminal charges for violence that they've experienced, which means that I don't have data on whether or not these certificates have been used in this setting. But from our experience, and maybe it also speaks to the fact that violence is hugely underreported because people are in fear and because people have other also priorities and needs as they move onwards and continue on their migration journey. So yeah, sorry not to completely answer your question with actual data on legal proceedings, but this has also been what we've observed through our missions.
Additional question, did MSF ever try to realize legal proceeding against the authorities in these countries?
So it's up for the person who's experienced violence to determine and to provide consent and to decide whether they want to press charges, of course, because it means that they'll be dragged through oftentimes criminal proceedings, which are extremely difficult, long, and might not come with the form of reparations that they might need at that particular moment. So the decision is completely up to the person who has experienced violence. We do, however, in almost every context in which we work, raise our concerns with the authorities at different levels. And in some cases that has meant seizing upon various institutions, the prosecutor, ombudsperson, in order to raise some specific concerns.
Thanks for the question. Any more questions or comments or experiences you want to share?
Yeah, thank you very much. It was quite disheartening to listen to, especially after the elections of last night, where the far right won here in the Netherlands, a party that even wants to get out of the UN conventions on refugees. But thinking about efforts and the efforts that MSF does to do advocacy and challenge the policies, the harmful policies, like you said, I wonder how you view MSF's role in relation to, let's say, the normal healthcare infrastructure and healthcare professionals that often, like you said, the access to care is so restricted that people don't reach hospitals and the normal healthcare system. But I feel that how can we make sure that, or how does MSF think that we can involve all healthcare professionals to stand up against this and to raise a voice more strongly?
Yeah, it's a great question. In terms of the barriers to access to care, this is a huge problem today, and it's also one of the reasons why we're not only present sort of at European borders, specifically where people experience physical violence and everything else, but we're also present in places like Brussels, in places like Paris, Marseille, because people face massive structural barriers to accessing care, and I would even go as far as maybe suggesting that this is a form of deterrence policy as neglect or exclusion. In these particular contexts and in other contexts as well, for example, we've worked on sort of bringing into the fold and raising awareness on these consequences and trying to raise awareness as well to sort of medical ethics boards and then unions which represent medical professionals and to try to show that this is a concern to public health and to the medical profession in general. One example is something that's been debated in this particular period in Brussels. They're trying to pass an amendment to a sort of long-standing piece of legislation, which, if it passes, and it was discussed yesterday in the Commission, so it passed the first level, but if it passes, it could have the consequence of imposing forced medical examinations on people in detention centers. And so, of course, this speaks to the core of medical ethics, and it speaks to the core of how doctors and public health can be co-opted by sort of harmful border management policies. And so this is also, as awful as it is, it's an opportunity to highlight this as well to people working within the medical sphere, so to doctors, to medical professionals, public health professionals, and to show the relevance of this is when the very core of medical ethics are at risk and are at risk being compromised, then I think it also provides further opportunities for sort of coalition building and challenging these practices.
And you're also welcome to join the Lancet Migration as a platform for advocacy. Any more questions? I recommend a book. Okay, over there. There's a book that I really recommend you read called My Fourth Time We Drowned, if you're looking for a Christmas present or something to read over the holidays. It's a bit depressing, but it's very depressing. But it's written by an Irish journalist, Sally Hayward, who documented the experiences of migrants in Libya who were trying to cross over to Europe, and the systematic pushbacks that are actually mainly funded by the EU in many cases, and also the response by the UN and other organizations. So it's called My Fourth Time We Drowned.
Thank you. Actually, I was supposed to ask the question other colleague already asked, but I will go a bit further. One domain, in your experience, like when access to medical care, especially when you send the patient to hospitals, what kind of barriers in both in policy level, like in Netherlands, undocumented immigrants, they are supposed to get the medical facilities, the policy is there, but in practice, many of the medical professionals, they don't know that policy is there. So what has been your experience working with these hospitals, health institutions? Thank you.
I think the experiences range tremendously, and there's a spectrum of experiences. At the maybe most problematic spectrum, I can raise the example of Poland, where, as I mentioned during the presentation, we meet people in this sort of densely forested area at the border with Belarus. And there we sometimes meet people who are in really sort of dire condition from a health perspective, and who really should get to hospital as soon as possible. And we see that people are reluctant to do so because they're afraid that if they go to hospital, this will result in them being pushed back. So in the most sort of abusive manifestation is the ways in which health and border management have been completely intertwined. In the Polish case, it means that as soon as we call the ambulance, the first people that arrive on site are the border guards. And in the Polish context, it means that it's the border guards who have been deciding who should go to the hospital or not. In the case of not, it sometimes means that the person gets pushed back immediately. In the case where someone goes to the hospital, we have testimonies from patients who have said that they pleaded at the hospital to be able to stay and to seek asylum. But we know that they've also received reports from patients who have been taken by the border guards directly from the hospital and forcibly returned to Belarus. There are also different versions of this. In Serbia, we also meet people who come with their papers from Hungarian hospitals, saying that they were pushed back directly from the hospital. In Italy, we see patients who were hospitalized in cities like Menton and Nice, who were also taken from the hospital and pushed back. So this linkage between border management and care is extremely dangerous in terms of being a huge barrier to people even thinking that they can seek care in the first place. And then in other places like Belgium, for example, where in theory there is access to emergency medical care for everyone, including undocumented migrants, we also see that there's huge administrative barriers. There's the fact that, as you mentioned, medical professionals don't know what their duties and obligations are. People don't necessarily know either what services and rights they're entitled to. Language barriers, and then there's also the fact that care is not adapted, that people don't necessarily speak the language, but also have experienced multiple forms of violence along the journey and are not necessarily met with forms of care that meet people's needs. So there's sort of, I think, different scenarios, but definitely a lot to work on in terms of access. Safe access, I think, is the most worrying thing, or lack thereof in many settings, but then also just removing the barriers altogether.
Yeah. And maybe thinking of the session this morning on screening in migrants, something we can do as health professionals is to think about asking the question, along with all the infectious disease and psychological effects, also ask about violence if you're in a safe setting to do so. Any final question before we close? Well, thank you so much for attending. I hope you learned something, and sorry to end on such a sad topic, but I hope you have a good lunch and enjoy the rest of the conference.